Hello, my name is Graham Selkwick, and this is my Propranolol and Verapamil overdose presentation using PowerPoint for integrating paramedic trauma science. Today's date, October 5th, 2020. My student number is 117-218-84. So the case study that I'm going to be discussing, we were called for a emergency response to a 55 female unresponsive, arrived to a residential townhouse. We were led upstairs to the bedroom by the husband. We find the female patient laying supine in bed with gurgling respirations. So in the primary survey, we assess that the scene is safe. There is one patient, access and egress via one floor staircase. Initial level of consciousness, she is unresponsive to pain stimulus. Circulation, she has a carotid pulse, feels slow and regular. Unable to find radial pulse at this time. Airway, there is emesis in the airway with snoring respirations. Breathing, she is tachypnic and shallow, but effective at this time. On rapid trauma survey, you do not find any obvious injuries. So primary survey interventions and secondary survey. So position patient 3/4 prone with immediate suctioning of the oropharynx. Placement of an OPA or NPA, basic airway adjunct. Consider the need for iGel, subglottic airway, or endotracheal tube, and plus or minus supplemental oxygen. Obtain an initial set of vitals and gather history from the husband. Husband states that the patient has had increased depression since losing her job. She has a past medical history of hypertension. Medications, Verapamil 100 milligrams 3 times daily, and Propranolol 320 milligrams 2 times daily. She has next to her, on her kitchen or on her cabinet next to her bed, she has empty prescription bottles, which were filled out about 3 days ago. So thinking of differential diagnoses for symptomatic bradycardic patient, ischemia. So with inferior acute myocardial infarction, with right ventricular involvement, due to the SA node and right ventricle being supplied by the RCA, occlusion may cause decreased myocardial contractility in addition to Brady dysrhythmias, heart blocks. Another differential would be electrolytes, as in hyperkalemia, which you would see in levels greater than 7.5 bradycardia wide complex QRSs. Hyperkalemia can be caused by increased intake, decreased excretion, and or extracellular shift, typically in the setting of chronic kidney disease, missed dialysis appointments. So beginning with propranolol, as a lipophilic, non-selective beta-adrenergic receptor antagonist, beta blocker, class 2. It has beta 1 and 2 blockade, resulting in decreased heart rate, decreased myocardial contractility, decreased myocardial oxygen demand, and decreased blood pressure. It's indicated for the use of hypertension, migraines, angina, portal hypertension, infantile hemangiomas. Onset PO is typically 2 to 3 weeks. Duration PO is either 6 to 12 hours or 24 to 27 hours with the extended release. It is metabolized by the liver and eliminated in urine. It may cause sodium channel blockade and overdose, leading to widened QRS and ventricular dysrhythmias. So with propranolol overdose, clinical presentation, serum levels greater than 0.5 micrograms per milliliter are considered toxic. Beta-1 blockade, you're going to have bradycardia with hypotension, decreased contractility. You will see AV nodal blockade and bradydysrhythmias. You will get central nervous system depression, delirium, seizures as the drug crosses the blood-brain barrier. Pulmonary edema, hypothermia, hypoglycemia, which is not as common. ECG findings with propranolol overdose are widened QRS, prolonged QT syndrome, ventricular dysrhythmias. High serum levels may lead to hepatic oversaturation, leading to prolonged elimination time. There is no known antidote for propranolol overdose, and dialysis is ineffective. Verapamil is a non-dihydropyridine calcium channel blocker, class 4 antidysrhythmic. It inhibits calcium influx into myocardial cells and vascular smooth muscle cells. It inhibits myocardial contraction, binds to alpha-1 calcium channels, inhibits vascular smooth muscle contraction, which dilates coronary and systemic arteries, blocks calcium influx into nodal tissue, causing decreased SA and AV node depolarization. Verapamil is indicated for hypertension, angina, SVTs, chronic AFib, and paroxysmal SVT. Onset PO is 1 to 2 hours, duration PO 6 to 8 hours. It is also metabolized by the liver and eliminated in the urine and feces. With verapamil overdose, the clinical presentation, with serum levels greater than 9 micrograms per milliliter, considered toxic. Verapamil is the highest toxicity amongst other calcium channel blockers. Suppressed SA and AV nodal activity. Again, you'll see bradydysrhythmias, decreased myocardial contractility, and also peripheral vascular resistance decreased, leading to severe hypotension. ECG findings, you'll find sinus bradycardia, AV node blockade, as in first degree heart block. You can also see second, type 1 and type 2 and third degree block, prolonged QT interval. You can see seizures, coma, rare unless in the presence of co-ingestion, pulmonary edema, nausea, vomiting. Also with verapamil, dialysis is ineffective. Hepatic oversaturation may prolong elimination. So with propranolol and verapamil co-ingestion, the synergistic effect has cardiovascular depressant mechanisms. Co-ingestion at toxic levels will lead to severe depression and myocardial contractility, severe AV node conduction delay, vasodilatory shock from calcium channel blocker toxicity, cardiogenic shock from synergistic effect of beta blocker and calcium channel blocker toxicity. You can see bradycardia, severe hypotension, acute heart failure with pulmonary edema, death from co-ingestion secondary to hypotension, cardiac dysrhythmias, and profound cardiovascular failure. Verapamil may inhibit propranolol clearance, thus increasing the plasma concentrations of propranolol, and peak toxicity may be delayed for several hours due to the sustained release formulas. Secondary survey findings, we're discussing the case study again. Vital signs of physical exam. Heart rate is 30 regular in a sinus bradycardia with first degree block. QRS 150 milliseconds. BP is 78 on 40. and is equal bilaterally. Oxygen saturation 88% on room air. Blood glucose is 14 millimoles per liter. She's tachypnic at 24 respirations per minute. Coarse crackles at bases bilaterally. Minor expiratory wheeze. 12 lead non-diagnostic. Sinus bradycardia with prolonged PR segment and wide QRS. No ST changes or T wave inversion. Skin's pale, cool, clammy. I also find jugular vein distension, equal chest wall expansion, delayed capillary refill, pupils equal and reactive at 3 millimeters. So the initial treatment for beta blocker, calcium channel blocker overdose, airway and ventilatory support, IV access, 18 gauge, large bore ×2. You want to increase chronotropy, consider atropine 0.5 milligrams to a max of 3 milligrams. May be ineffective in the second and third degree AV blocks. You can consider transcutaneous pacing, but it may be ineffective in mechanical or electrical capture. Increase chronotropy and inotropy using pressors such as epinephrine, 2 to 10 micrograms per minute. Shorten the QRS alkalinization of the serum, counteract propranolol, sodium bicarb 1 milli equivalent per kilogram, titrate to narrowing of the QRS. Calcium channel blocker overdose treatment is recommended. Calcium chloride 1 to 2 grams or calcium gluconate 3 to 6 grams. Fluid administration, do judicial boluses of 5 milliliters per kilogram to a max of 20 milliliters per kilogram, or 1 to 2 liters. You want to watch for worsening pulmonary edema. Torsades may occur secondary to the prolonged QT, the treatment, the pre-hospital treatment for that. Meg sulfate 2 to 4 grams. You want to increase myocardial contractility and heart rate. Glucagon is also an option. Loading dose is 5 to 10 milligrams. All right, so discussing the specific treatments here. Sodium bicarbonate for the treatment of wide QRS. So just basic anatomy, physiology. QRS represents ventricular depolarization via voltage-gated sodium channels. There's 3 states. They are closed, open, and inactivated. Certain toxins or agents such as propranolol can cause sodium channel blockade via modulation of any of these 3 mentioned states. And this results in slowed ventricular depolarization via the His-Purkinje fibers. Sodium bicarb mechanism of action in wide QRS is not exactly known at this time. Narrowing of the QRS may occur through increased sodium concentration, serum alkalinization, or both. Higher pH may increase protein binding and decrease the amount of free drug. Another proposed treatment for beta blocker toxicity is high dose glucagon. So glucagon has a positive ionotropic and chronotropic actions on myocardial cells. Glucagon receptor is activated, which increases the cyclic AMP production independently from beta adrenal receptors. The onset of action in calcium channel blocker beta blocker toxicity is about 1 to 2 minutes. Limited duration. It is only effective for 10 to 15 minutes. Requires a constant infusion, therefore considered a second-line agent. Loading dose of 5 to 10 milligrams, followed by an infusion of 1 to 10 milligrams per hour. The adverse effects of glucagon are nausea, vomiting, hyperglycemia, hypocalcemia. Limited use in the pre-hospital setting, but may be used as an adjunct to other positive inotropes. All right, discussing supplementary calcium for calcium channel blocker overdose. calcium administration is indicated in calcium channel blocker overdose with hemodynamic compromise. The loading dose, and there's a loading dose for calcium and a continuous infusion, which is required to sustain an increase in the blood pressure. Patients will require frequent ECGs and serial blood work to avoid hypercalcemia during this calcium treatment. Calcium may be effective minimally or only transiently in some patients. Other therapies may be more effective in this case, such as lipid emulsion, glucagon, and HIAT, which will be discussed shortly. So returning to the case study, just discussing the transport decision. It's best to determine the time of ingestion as accurate as possible, or when the patient was last seen normal. If less than 1 hour, but could be 1 to 2 hours, consider rapid extrication for transport to hospital for gastric decontamination. You're going to want to request additional resources, as this is a patient on a second floor walk-up, second ambulance or fire department for extrication. Immediate airway and oxygenation support, in this case, endotracheal tube with Ballard suctioning, as the patient most likely aspirated at this point, and end tidal telemetry. As mentioned before, you want to get large bore IV access, preferably 2 lines. Pharmacologic interventions to increase the heart rate. So treating with atropine 0.5 milligrams to max of 3, transcutaneous pacing, epinephrine 2 to 10 mics per minute. You can consider glucagon and calcium chloride therapies, which in British Columbia are a mandatory call to our online physician for patients with a pulse. Transport to the closest available hospital would be an emergency transport as a patient is unstable, hospital notification during transport, and just for this patient, constantly reassess and serial 12 leads on the way to the hospital. So at the hospital, further treatments for this co-ingestion overdose, gastric decontamination, as mentioned. Some sources say 1 hour, others say 2 to 4 hours from ingestion. Activated charcoal is the therapy. Increased blood pressure with other pressors such as norepinephrine and dobutamine. Increased contractility and blood pressure, high dose insulin, therapeutic plasma exchange, intravenous lipid emulsion, and for those patients not responding, the potential for eCPR, life support. So just talking briefly about high-dose insulin euglycemic therapy is another proposed treatment. Glucose is the preferred substrate used in shock states. Insulin increases the intracellular transport of glucose in addition to lactate and oxygen. Insulin has a calcium-dependent inotropic effect, and in some animal studies has shown to promote greater hemodynamic stability in propranolol verapamil overdose compared to adrenaline and glucagon alone. There has been some improvement in cardiac output and blood pressure. The onset of HIAT is approximately 15 to 60 minutes. It is obviously supplemented with IV dextrose, 10 to 50% preparations to maintain blood glucose within normal parameters. And that is my presentation. Here are my references, and thank you for listening.